All right, thanks everybody for joining us. We're going to be talking about hemoabdomen. It's Dr. Justin Ganji, and I'm Dr. Shadi Arafij. It's a pleasure.
Just to kind of introduce us, so I'm Justin Ganji. I'm a surgeon. I'm in Maryland, Gaithersburg right now. I did my training at Virginia Tech, and then did all my private practice kind of specialty training in private practice. So actually, where I'm at currently, I did my rotating internship, and then did my residencies and internship in Virginia, and then stayed there for a bit, and then ended up coming back to where I'm at now at VRA. I do also adjunct teach at Virginia Tech and have their students come through us and rotate through surgery. That's my passion, that's my baby, that's my OR, my minimally invasive IR suite. That's kind of what I would love to do every day. So yeah, that's me.
I'm Dr. Shadi Arafij. I graduated from Cornell University in 2006. I then became board certified in surgery at Long Island veterinary specialist. I then went from New York to out west and practiced in California for a bit, managing facilities there for about 2.5 years. And then now currently I'm the owner of Triage. We've been doing that for about 5 years now. So this is the outline that we'll go through here. If folks have any questions anytime, feel free to interrupt. Our goal is to make this very practical, clinical, so that you can actually utilize this in your own practices. So we'll begin by categories of hemoabdomen, follow that with clinical signs, initial stabilization, the history, physical exam findings, various diagnostics, medical management for hemoabdomens, how to handle client communication, surgery, of course, post-op care, prognosis, and any questions folks have.
So, we're going to kind of talk about, I think when you think of hemoabdomen, you think mainly splenic mass, right? That's going to be the most common thing that we probably deal with. But we're going to break it down just into just a true hemoperitoneum, which is just the pathological accumulation of blood or hemorrhage in the abdominal cavity, which we know. So kind of two main categories for that. There's the traumatic and then our atraumatic kind of spontaneous hemoabdomens. And if we look at them, if you look at traumatic, there's going to be two types really. There's blood trauma, and then in this nice example here of penetrating trauma, where you can see this one was a hemoperitoneum, but those are going to be the two main kind of presentations for the non-spontaneous ones that we see. And then if we look at the atraumatic ones, it's not just spleens. It's nice to think that's what it is, and majority of the time it is going to be a spleen. But if you look at it, this is just a small list of all the possibilities there. Liver torsion, splenic torsion. Many times in GDV, you're going to have a bit of a hemoabdomen as well from tear in the short gastrics, and then other non-cancerous things. So obviously splenic tumors and adrenal tumors, but coagulopathies, and really any tumor can bleed for the most part. So, and I will tell you that there are many times you go in thinking it's a spleen and sometimes it's not, and the adrenal I would say is kind of up there at the sneaky hemoabdomen. It's not the fun one to deal with, so just have it on your radar. When we look at them, the funny thing with hemoabdomens is, as you guys probably all know, is that they come in two ways. They're either coming in half dead, collapse, this is a slam dunk hemoabdomen, or it's the dog that's been just kind of off, very slightly off, very non-specific symptoms, maybe vomiting a little bit that can come in. So I would say that's the two most common ways that I would say we see them most of the time.
So the other clinical signs and physical exam findings that you're going to notice with these pets, in addition to what Doc said, is weakness, abdominal distension, tachycardia, tachypnea, pallor, and collapse, all signs, as you mentioned, of hemodynamic instability or shock. And
when you're addressing them when they come in, depending, how many of you guys work in an ER setting? Okay, and then how many of you guys are seeing hemoabdomens pretty regularly? All right, so you guys are all familiar. So this is pretty basic stuff that you guys would see. So the first thing you're going to want to do obviously is address their hemodynamic instability, which is going to be a combination of crystalloid therapy, really blood products are going to be important here, and then that kind of goes hand in hand with oxygen. A lot of these guys are hypoxemic from their blood loss. You will get some that come in with varying degrees of cardiac arrhythmias, whether it's just a hypoxic injury causing myocardial insult, or if it's true splenic disease causing cardiac arrhythmias, or some of these dogs have cardiac-based tumors on hemangiomats and stuff like that. So obviously stabilizing them, and then I would say also importantly, don't forget about the analgesic component of it. People, if you if you have a splenic mass, which is pretty uncommon, but like the capsule stretching and rupture of these organs is actually quite painful, and that can be contributing to the shock and the pain. And you have to balance it pretty well. You don't want to like over pain control them and have to kill them if they're pretty unstable. But you do want to, you know, make sure you have that kind of part of it. And when you're picking your analgesics, at least from a surgical perspective and also from a critical care perspective, I would say safer to use things that are reversible here. You know, so even if it's like fentanyl or like a low dose of like methadone or something like that, just keep it comfortable. Something that if you have a problem, you can take it away pretty quick.
You can always start low dose, right, and titrate your way up, but it's much harder to reverse unless using a reversal agent. And so to dive in deeper about the oxygen therapy, there's just a short list of reasons why hemoabdomen dogs may have issues with oxygen transport. So they've got decreased circulatory red blood cell volume, which is of course anemia, exercise-induced systemic oxidative stress. Maybe they have restrictive lung disease like pleural effusion or metastatic disease, anemia, we mentioned, DIC, so coagulopathy, either as their primary condition or as a sequela to something else that's plaguing them. And we do see DIC in 12% of solid malignant tumors, and there's an increased rate of DIC with hemangiosarcoma. So just a short list of reasons why oxygen transport is debilitated and why it's important to address it. When you talk about stabilization further, a couple of points. Ideally, if you know that the patient is coming in ahead of time, and you may not know over the phone it's a hemoabdomen versus any other reason for sudden collapse, but you can prepare. And so you can have these products available to you in your facility, or have them ready rather in your facility, so your staff can receive that PET once they arrive. 2 large IV catheters are ideal, is the biggest you can get in that patient. Transfusions, as Justin said, and then there's literature out there on both small animal and large animal about low fluid volume resuscitation. Obviously it goes a bit beyond this talk, but the old school method of high fluid volume is being challenged by maybe lower dose fluids are more effective and safer for the patient. So we'll see. There'll be plenty of studies on that, I'm sure.
So when you work on this on these guys, you kind of break down the initial diagnostic workup. Your history and clinical signs are going to be important here, especially for kind of breaking down some of the potential causes for the hemoabdomen. Your physical exam is going to be pretty telling for a lot of these guys as well. And then I think point of care diagnostics are really helpful in this situation because they're quick, they're readily available, and can give you a lot of information when you need to make a quick decision, whether it's talking to a client about what's going on and also making a game time decision. Just like anything, especially because surgery is going to be involved too, anesthesia, blood work, and then really, diagnostic imaging. These are all the things that are mainly workups for a lot of things, but here, very, very important. And we'll kind of talk more about the different types of, things we can use to go through this. When you're talking to these patients, I think it's important to know about a history of trauma, right? For your non-spontaneous hemoperitoneum, the dog just get run over by a car, got up and walked away. Did somebody hit it with a bat? Didn't like it down the road. Is there rodenticide available? You hate going into an exploratory surgery to find out that it was a rodenticide toxicity. That's not fun for anyone. Sometimes the owner will be like, yeah, this dog's been belly getting a little bit bigger over the last couple of weeks. Then you find, it's been just filling up with small amounts of blood. They're not always an acute bleed. Sometimes they're chronic, and they can tolerate that a lot better. That's those nebulous ones that walk in pretty damn stable, but they have a huge hemoabdomen. And then also really important to know, did they have recent surgery? Because sometimes we have iatrogenic, slippage of ligatures, testicular ligature slips and pops in the abdomen and goes on that. So all this kind of stuff will help you tie in to what the cause is and what you're going to be doing about it.
And clients often will ask, well, how did this happen so fast? They were fine yesterday, what's going on? And if you probe further into the history, you'll realize there were actually bouts of intermittent lethargy and weakness that happened in the past, maybe weeks or months ago, and then it spontaneously resolved, and the pet was fine again. And maybe it was an older dog, they're like, oh, he's just older, just slowing down, today's a bad day. But if you investigate this, my suspicion is that they're having periodic hemoabdomens, and the body takes care of it, and then they're stable for a while. So if you probe further, usually there's some sort of a history that maybe you can point to chronicity.
And so your physical exam will be pretty telling in these guys too. Obviously most of them, well, depending on how long they've been bleeding, but they'll probably have some degree of an anemia, whether it's an acute one or that. So you can probably pick up on that pale mucous membranes. They're maybe tacky depending on what level of shock they're in or if they're in shock at all. Typically, you'll find, I mean, the classic presentation would be that distended abdomen, right, with palpable fluid wave, but that's not always the case. Sometimes it's a very small amount of hemoperitoneum that you can't palpate or feel. You might feel a mass to come with it. That's always nice. You know, but then if you see a dog that's got petechiation and ecchymosis going on, hemoperitoneum, that's when I'm going to be starting looking more about, like, okay, maybe they didn't tell me there was sort of NSI toxicity going on, but is there some history of it? And that's a dog that, you know, automatically, you know, you're going to need to check for coags on this thing, you know, because that's just not a typical thing that we see in most of the, you know, splenic masses of rupture. You know, how shocky are they? You know, that's going to dictate where you go from there and what you treat. And then I don't think it's wrong, and it's probably right, to stick an EKG on these guys when they're coming. Obviously, if you hear an arrhythmia, that's the side. They're going to be tachycardic if they're in, you know, some compensatory shock. But you will pick up, and sometimes it's hard to pick up on a single VPC if you're not listening long enough, which, you know, you're doing a lot of stuff to these guys. So I think sticking an EKG on there just to see is very helpful in these guys.
And I'll dive in just a little bit with the petechiation ecchymosis part because I do see some confusion with regards to that clinically. Let's remember that coagulopathy involving stage 1 to the initial platelet plug, right? That's the first step of hemostasis. That's how it's going to present itself with superficial signs of a bleeding disorder. And so that's either going to be von Willebrand's issue, a thrombocytopenia, or a thrombocytopathia, whereas stage 2 involves our PTT testing, right? The second stage of coagulation then involves the fibrin clot, and that's different. That's going to cause a deeper body cavity type bleeding, so hemoabdomen or hemoarthrosis or hemothorax. So keep those things distinct, and then of course stage 3 is the whole DIC and fibrinolysis portion. So in cases like these, there may be overlap, there may be multiple issues going on, but just keep that in mind when you're figuring out diagnostics, depending on what the patient is presenting to you in terms of a coagulopathy.
How many of you guys have access to an ultrasound pretty readily available? That's awesome. Okay, so I mean this is like your best friend in a hemoabdomen initial, you know, kind of triage situation. You could pretty quickly diagnose at least some degree of fluid in the belly, you know, with the ultrasound. And so, you know, your fast scans, your POCUS, doing the chest also. I mean, I think most of us, when you do it, you're going to scan the abdomen, scan the chest too, just to see if there's any pleural effusion or in there as well. PCV, really quick test you can do, and then tap that fluid. You know, I mean, I would tell you, it's not uncommon that I've had a dog sent to me for surgery with the assumption of a hemoabdomen because it's anemic and it's got a belly full of fluid. And I distinctly remember we had one come in and, you know, it had not been tapped, and I tapped it, and it was in right-sided heart failure. It just happened to be anemic. You know, that would have been a huge mistake to just take that dog to surgery. It would have killed it, you know. So really easy tests that you can do that give you like 90% of the puzzle just by doing that.
You know, often enough we kind of have a preconceived notion of what we think we're gonna find. We have to actually search for it, and then it may be what you thought or it may not be. But that's a very important point.
All right, so baseline blood work, right? You know, CBC, chemistry, we do it on everything, but really important, there's a lot of factors that you're gonna look at on that CBC. Obviously, we're dealing with anemia, so we're gonna see if it's regenerative. Many times they're not gonna be if it's an acute bleed, but it might be a non-regenerative chronic anemia. Your platelets are gonna be, again, part of like, is that bleeding because of platelets? Now, I will tell you, just from experience, that it's not uncommon to see them have a little bit of a low platelet count because of consumption as they're losing all that blood. And that doesn't always mean they need a platelet transfusion. And I kind of talk about that a little bit later, but like, I would say probably 80%, 90% of the surgeries, splenectomies, or let's say they go into surgery, probably are thrombocytopenic. They're not gonna bleed out on you just from that, because they'll get it back, but you will probably see that. Your chemistry, you know, again, these are gonna be important for looking for other things in an older dog. Gonna have some abnormalities, but you know, let's say you have the hemoabdomen that comes in, and you're gonna, again, everyone's thinking spleen, but this dog's got massively elevated liver values. You might be dealing with a HCC that's ruptured, you know, instead of a splenic mass. So again, things that might trick you into other potential causes, and then coags, you know, again, you need to rule out a coagulopathy here of some sort, and then having a blood type and cross match, not wrong. You know, if you don't have the products, then I guess there's no point in doing that, but these are all just kind of good baseline things to have for these patients when they're coming in.
So to dive in further with the CBC, these are of course the findings you're looking for. One point I wanted to make with this was anemia. You try to characterize it. So often enough, if we see an abnormal white blood cell count, we just say, okay, they have leukocytosis, and that's it. When really we should be characterizing it. Leukocytosis characterized by neutrophilia, monocytosis, eosinophilia. So same thing with anemia, you want to characterize it. Severity, is it non-regenerative or regenerative? Is it macrocytic, microcytic? Is it hypochromic? And these characteristics may help you figure out what condition you're talking about in your overall picture of working up a hemoabdomen. Certainly there could be some overlap with conditions and these parameters, but even just for medical record purposes, make sure you characterize the anemia.
So kind of diving into imaging, you know, radiographs are going to be readily available, so that's certainly something that is, I think, always a nice baseline to start with. You know, sometimes you can catch a huge mass there, or you'll just see the decreased serosal detail just to confirm, you know, if you're not using a POCUS. But thoracic rads, you know, I think if they have a coagulopathy, you know, you still might want to take them to see if they have a hemothorax, or you can really scan that, but also for metastatic disease and staging, which is going to be important for prognostic information and for owner's decision making and stuff like that. Abdominal ultrasound, you know, if you have the ability to do it, I think a full one is important. You know, may not always have the ability to do that in the middle of the night, but if you do, if it's in the middle of the day, it's not wrong to get it. Because again, kind of the point of this is that a lot of times they're going to be what you think it is, but sometimes it's not. And it's better to always know that before you go in than when you get in. If you have CT available, I mean, there are cases when you should be reaching for this. And I would say, we could talk, but we'll dive into that a little bit deeper. But how many of you guys have access to CT like readily? Not a lot. But ultrasound, we already kind of touched on that. Okay, yeah, that's probably it.
So just to dive in further again with the thoracic radiographs, these are some of the things you're looking for, not all the things. Any alterations with the cardiac silhouette. So for example, maybe this is cardiomegaly and it's pretty globoid. Maybe this is a pericardial effusion or pericardial tamponade. So effusion in the pericardial space or pleural. So here's an evidence here. It's hard to see, but there's a radiopaque linear structure between the lung lobes. That's probably pleural effusion. Any lymph node enlargement, and of course metastatic disease. And here's a severe case, of course, of pleural effusion.
And don't forget that a lot of these, if it is a splenic mass, I mean, like some of these guys do have heart-based metastasis that are present already. You can pick those up, like Shadi was saying, on a radiograph. Sometimes you see that slight difference there. So that's, again, if you're seeing that, it might be a case where you may want to, you know, get an echo or something like that done on these guys ahead of time. And
even if you're not proficient in echocardiography, you can probably scan the chest and just look for that pericardial effusion. It should be fairly obvious. You don't always get a large enough volume to notice it. Sometimes you do require a bit more expertise with it, but it is a helpful thing to try and do. And then with abdominal radiographs, especially if you don't really have abdominal ultrasound available to you, sometimes you'll see a large soft tissue mass in the area of either liver or spleen, and it's causing displacement of the small intestines. But ultrasound, of course, will help. In these two cases, there's splenic masses. So depending on what you have available to you, these diagnostics are well worth it.
Can I ask you a question on last X-ray?
Yes?
Is that mineralization?
Here?
Yeah.
Yeah, so truth be told, I got this from the internet. So I don't know but let's look at it as if we just took these. So if I have only the one view here, I'm seeing these mineral-like or metal-like opacities in the abdominal cavity, and I'm thinking, okay, what can that be? If I'm looking at the gastric axis here, the stomach, you see it's pretty empty, just some gas, maybe a little bit of fluid, but these seem to be outside of that. And then, of course, we have this soft tissue mass displacing the small intestines caudally. That could be, okay, maybe liver, maybe spleen, could be something else like lymph node, but chances are it's one of those two organs. And again, its mineralization is sort of outside of that. And so, but there's plenty of structures here, right? Gallbladder lives here, certain liver lobes live here, the spleen could be in here, and then of course colon is quite mobile. So if I had to guess from this, I would say it's probably not in the GI tract. Don't know for sure, I need other views. But I'm going to guess maybe this is a calcification of malignancy associated with either this liver mass or if this is a splenic mass, whatever it may be. That's my guess. You would need other views, right? You'd want to have at least a VD and then possibly even the other lateral to try and figure out where this thing lives. Gallbladder is another thought in my mind for this. But as far as this case in particular, yeah, I just took this from the internet, but that's how I would evaluate it if this was something I was seeing. So,
kind of back to CT, just I know it's not always readily available, but like when when I kind of think to myself, like, when would I consider more advanced imaging for a case like this? And really, it's going to be, for me, like, if I'm not sure, you know, if all the diagnostics we've done already point to, like, we don't know. So if we can't find the source of hemorrhage, let's say the rads look normal, you know, and the ultrasound can't identify a source, I'm going to be really anxious about taking that to surgery and, you know, not necessarily knowing what I'm going to get into. That's when I see adrenal tumors bleeding, because you don't always find them in a big pile of blood. And, you know, that's, for me, that's a game changer. You know, that's a surgery that, you know, if I was you guys, and I didn't have a lot of, like, resources, like, I don't want to dive into that not knowing that, especially if it's a right-sided adrenal tumor that's in the cava, you know, that's bleeding, because that's a whole different rodeo and it's fun. But, you know, it's a different game. So that's the case where a CT will tell you the difference between that situation and a splenic mass or something else. Also for, like, specifically for adrenals, like vascular invasion. Yeah, you can go and take an adrenal tumor out, but can you do a cavotomy? Do you know how, if it's got a thrombus going up to the, you know, the right atrium? Like, those are all, like, big game changers and things that I've encountered in clinical practice. And then it goes hand in hand with, like, and I say this because I do a lot of, like, options for non-resectable tumors, you know, which I challenge the question of resectability sometimes. It'll help you know if it's resectable or not. Like, for example, this dog right there is a massive, massive liver tumor, you know, that's there. So that, finding that out in surgery is something that is, you know, you have to be then prepared to take that out. And can you take it out or not? You know, what if you can't? Then if the owner is like, I want to do everything, it's not resectable, well, what can we do? Euthanize it? What if they don't want to? What if there's options? We could embolize it. We could do transarterial embolization. You know, we could do other non-invasive options to treat it. So I think I would challenge you that there are other options for things that don't always like have a clear treatment plan that we can do nowadays, radiation, stuff like that, for the right owner. And for trauma, you know, like that stick that was in that dog's chest before too, like, you know, how do you know you're gonna get in there and that thing's not going through the chest and the diaphragm and the spleen and something else? CT will have that. I mean, CT is not as unique as it used to be a long time ago. It's pretty readily available, pretty easily done. We can do it on an emergency basis a lot of times if they're gonna wanna go evaluate that kind of treatment option. And for pre-surgical planning and for metastatic evaluation. We know that it's gonna pick up smaller lesions. We know it's gonna pick up lymphadenopathy and stuff like that that might not get picked up on an ultrasound. So I would challenge you to consider that in cases before you just dive in to be like, should I be going in on this one or should I step back and take more advanced imaging for that case?
And the other good thing about CT scan is you need minimal sedation for these pets. So if you do have to perform a CT on an emergency basis on an unstable patient, you're trying to stabilize them while you're doing the scanning, a couple of minutes and a really good CT scan, a good technician can get that done with minimal sedation needed. So it's not like MRI that requires full general anesthesia. It can take hours to do. These are pretty straightforward. But also I will add, because Justin and I are a bit spoiled, we have all the nice tools, right? We can walk down the hall and have an MRI there, or a CT scan, we have specialists. So if you folks don't have that kind of stuff, you're like, boy, you know, my clients wouldn't even go for this, even if I had that as an option. Well, then use your clinical experience. An older German Shepherd or Golden Retriever with signs of hemoabdomen, and chances are it's going to be some sort of intra-abdominal mass, probably liver or spleen, but a 3-year-old miniature poodle with hemoabdomen, although possible, probably less likely, and further investigation is warranted. So use your clinical expertise to kind of differentiate, especially if you don't have all the fancy stuff. So here's two other examples. This is another intra-abdominal mass. Looks like it's associated with the spleen. And this is evidence of metastatic disease in the lungs. These are both CT scans.
You don't always have to, you know, cut them. And I guess the next thing is figuring out before we dive into surgery is, do you need to cut this case or not? You know, and so obviously if it doesn't need surgery, then you're going to be looking at things like a coagulopathy. You don't need to cut that. You shouldn't be cutting that. Is it a post-surgical bleed? We just had one before I came up here the other day that was a slipped ligature on from post-castration, so 2 days prior. Pretty, I will tell you that dog was like set to go to surgery. They wanted us to cut it really bad, you know, and it didn't have that much blood in its abdomen. It was stable, and we refused, you know, which everyone likes to hear, a surgeon refusing things. But that dog went home and did fine. It clotted that time. So I would say that see if you really need to cut it just because there's a little bit of blood in there. If it's stable, maybe it clotted. I would say a lot of slipped ligatures I go back in on surgically are already clotted by now, and a lot of that bleeding was done. So maybe you just need to transfuse that dog, or just give it some time and see what happens. So some trauma is also blood trauma. You don't have to go in there and take the spleen out if it's ruptured. The body does a great job of clotting, and the momentum protects things. So, sometimes you do have to cut it, but see. So start with some supportive care. Maybe give some blood products, and then I would say, have you guys used antifibrinolytics a lot at all? Anyone use that? I mean, they're available pretty easily. Tranexamic acid and aminic proic acid. Those are things that you can use, and I use them frequently to try and see if it helps. And there are studies that show that it will help to, it's not going to stop an acute arterial bleed, but it's going to stop like that generalized oozing and ruptured like organ sometimes. And everyone's favorite Union Bio, which who knows if it does anything or not, but I think we all can shove that red pill in the butt and see what happens. And see what happens. So the other thing I'll tell you about this too, in terms of transfusions, is like consider patients where I know that how many of you guys have access to blood products readily? How many of you don't? So you're like split 50-50. Fortunately, they're pretty readily available, but there is a lot more thought process coming out on auto transfusions. And even in the human side, they've kind of switched over to that a lot because it's actually been shown to be a little bit safer, less complications. Now, you have to dive down that pattern of like, are you going to be transfusing malignant blood into the patient's stream? There are new studies now that question that doesn't really even change anything if they already have it in their bloodstream anyway. But if it's between a life or death situation, especially for something that's non-cancerous, I would be not hesitant to auto-transfuse these patients. It's very easy, very well tolerated, something you can do without access to blood products. If you're dealing with a cancer of some sort that's ruptured, then I would have that conversation with the owner. But if they want to do everything and try and they don't care, again, I don't think it's wrong to do that. And we have studies now to at least back that nowadays. So, let's talk about surgery then. So what are your indications? Obviously, a splenic mass, would need to come out, or splenic torsion, do a splenectomy. Liver masses, they like to bleed sometimes. You definitely will find them that start oozing, and then those need to come out as well. And liver torsion will cause liver bleeding sometimes as well. Adrenalectomy, and then also you do have to sometimes go in for surgical ligation of the bleeding vessel. This is probably the most common, I would say, surgical hemoperitoneum causes that we see. I would also question you, when you're seeing these cases, to take a step back also and just ask yourself, because I do it to myself many times, like, are you comfortable doing it? Should you take this dog to surgery? And that doesn't just mean, can you do the surgery or not? Are you prepared to handle the complications of it? Are you comfortable? Are you being pressured to do the surgery because your colleagues want you to do surgery? We should be doing the surgery. Are you comfortable doing the surgery? And if you get in there and there's complications, are you prepared to handle that? If you're going to go in there without imaging, are you able and ready to do a liver lobectomy? If you're not, have you done the right thing for the dog by going to surgery? Do you have blood products ready to give that patient if they need post-operative transfusion? If you don't, and they're already quite clinical, they need it, you may not have done good for that patient. You may do a great surgery and do a great job, but then they're dead post-operatively because you didn't have the right stuff to stabilize them. And these are questions I ask myself too. Sometimes we don't have blood products. And I say, maybe I should send this to a different hospital that does. It has nothing to do with your abilities, but is the owner aware of these potential risks? And also, another thing that I hear a lot, and I have strong feelings about is like, sometimes you get put in a situation to like, well, they have no money, we can't refer, we'll take them to surgery. Well, how much are you charging to do that surgery? Are you just doing a really, really complicated surgery for nothing? Your time is more valuable than that. Just because the owners are pushing you into doing it doesn't mean that you should do something for free because they want you to do that. So it's just questions that I get people ask a lot of time. They go, well, your worth is worth a lot too, and your time and stress level to do that. So just ask yourself these questions sometimes and make sure you're comfortable with the scenario.
One of the common things that I see as far as when general practices perform like a splenectomy, for example, is they do a great surgery, and the post-op care, which we're going to go over later, is a bit lacking, not as aggressive. And that post-operative care can really make or break that case. You can do the perfect surgery, but if you're not monitoring sufficiently, stabilizing or maintaining their stability post-op, then it may be a detriment to the patient. So the prepare to handle complications associated with the procedure and having a post-op plan is very important. Clear and direct client communication is key. If you're in that scenario where the client can't afford referral, they don't really want to, they love you, they've been going to you for decades, they want you to do the surgery, be frank with them. I've done X number of these or none of these procedures. I'm sure I can tackle it if you're accepting the fact that there's going to be inherent complications potentially with that, and here are all the downfalls. Plus, we're not a 24-hour facility. This dog's going to have to get transferred somewhere or go home with you, and then you've got to deal with this. If you're okay with all that, sign off on it, and we'll go. And it allows the client to be part of that decision making, so they don't feel they're being guilted to not go into referral, but also you're trying to save that dog's life. And it lets you, as a doctor, get more experience, right? The client has to agree to it. They've got to sign off on that and acknowledge it with you.
Yeah, and I say this also because the clients are, from my experience and others, like, they're not your friends. And they will quickly turn on you as soon as things start going poorly, no matter what. So I don't like getting bullied by clients. I speak a lot about that because I see it happen. I've had it happen to me, and like, now I don't take their shit. You're gonna do it my way, or you're not doing it, or you go somewhere else. And I think that everybody should do that because people nowadays are pretty rough.
Mm-hmm.
All right, so when you go into an abdomen, I think it's just a good part of doing that is to have an order, right? When you're going in there of how you do your explores. That always usually helps to cut out any uncertainties, okay? So for most of these dogs, you're gonna be going in for a standard kind of ventral midline incision, and give yourself enough room. Have the visualization to see everything that you need to see. And when I do that, I take out the falciform fat out of all of my explores because it gets in the way. Especially if you're working up by the liver, it's gonna get in your way. They don't need it, just take it out. And that way you have the visualization to see things. Probably the first thing you're gonna need to do is just evacuate all that blood because it's gonna come pouring out pretty quick. So just evacuate it, keeps your OR clean, keeps you clean. And then if you're gonna auto transfuse, that'd be the chance to go ahead and just collect that blood. And you can literally just, if you have a filter, you can just put it directly in to the patient right there. You can just go, hand off the syringes to your tech and they can do it if you're gonna do that. And then, in these situations, I don't sit there and do an explore first. Like, if it's a clearly, obviously bleeding splenic mass, get it out. Just stop the bleeding and then go back and look at everything once you've done that because you're just wasting time and blood. If you're waiting to give the blood until sometimes the anesthetist will be waiting or you have blood waiting to give to the patient as soon as you get the bleeding stopped, then just stop it real quick. Take that spleen out and then go back and do your explore. So that's where I would say the counteract to doing your normal systematic approach sometimes is if they're bleeding to death, just get it out and then go ahead and do your thorough explore. Even if you do that and you take the spleen out real quick and then you see there's metastatic disease everywhere, well, you've at least got the bleeding stopped. You can have that conversation with the owner. It doesn't really do anything worse to the dog to have that time to stop the bleeding and then make that decision to euthanize or do whatever.
And also, you may not know those are metastatic lesions, right? In an ideal world, you would warn the owners after removing the spleen and stopping the bleeding and say, hey, look, we're in surgery, spleen is out. There are these concerning nodules in the liver. I'm worried it might have spread. What do you want to do? Here are your options. We can either euthanize or we can biopsy the liver lesions. And can promise you'll have cases where if you euthanize the pet and if you had biopsy that would have been benign, it happens. So you can have malignant splenic mass and benign liver growths, right? So don't jump to conclusions just yet. Make sure you sample that tissue.
Yeah, that's really important. And I would say more so in the last few years, I've had more owners that they don't want to euthanize that pet on a table. And you've already stopped the major bleeding. Even if that thing's going to bleed in a couple of weeks or something like that, I would say more often than not. I mean, I think it's good to call, like Shadi said, calling them and being transparent about what you're seeing is very important from a liability standpoint too. But I would say 80+% of them, unless there's multiple active things bleeding, you can't stop it. They're going to bleed to death. They will continue. And they might surprise you and seek medical, chemotherapy or other advanced forms of therapy if they want. So I think it's a great point that you don't always know.
So just to go over some aspects of splenic surgery, because splenectomy isn't the only option. It is going to be the majority of what we're going to do. And then I'll mention an important point here, but you can have a splenic laceration repair and actually salvage the spleen. Let's say somebody did a abdominal explore, accidentally nicked the spleen, or they were doing a spade, they nicked the spleen on the way in through the linea. You can also have a scenario where only a portion of the spleen looks like it's diseased. We're going to talk about that right now. But you can do a partial splenectomy as well, and this is just a reminder of the vasculature. Now, an important point to make here with the partial splenectomy: never, if you see a splenic mass, you're only going to remove the splenic mass or that portion of the spleen and leave the rest in. Never. Never. The chances of having malignancy in our species are so high that you're not going to do it. In people, it's different. In people, they will do partial splenectomies and then wait for the histopath to come back. We don't have that luxury. If the malignancy rate is too high and it's just contraindicated, the only time I've ever seen this procedure done, I've done it once in my 18 years, is that the spleen was entrapped in a hernia, an intra-abdominal hernia, and it was a clear line of demarcation where the spleen was entrapped. And I thought, okay, this I can actually remove part of the spleen, right? Chances are this is not a cancerous thing. I still biopsy that part that I remove, just in case, but that's the only time I've ever done this. Otherwise, you are doing a splenectomy, hands down, if there's a splenic mass. And then this is just a reminder of splenic torsion. Rare, I think I've seen maybe 2 in my 18 years, but do not unravel this. If you go into an abdomen thinking it's going to be a routine splenectomy, and you find this, and you think, oh wow, maybe if I undo this, it'll save the spleen. It won't. And you're going to have such severe oxidative damage to the patient, free radicals, all that stuff. And I've seen it happen. And you'll see tachycardia, ventricular tachyarrhythmia rather, VPCs like crazy, and then they'll code. And so that's what happens with these animals. So do not unravel this. Perform the splenectomy with it still in torsion, and then move on with the rest of the surgery.
Yeah, so this is just kind of a look for the kind of vasculature path of the spleen. As you can see, there's a lot of important vessels that go to other organs. So be cognizant when you're doing a splenectomy of where you're ligating and where you're taking this. I've seen spleens get taken down way too dorsal by the hilus, and I mean, if you look right there, the kind of the pancreaticoduodenal will get tanked, and then you'll have like a pretty bad pancreatitis and situations there. So when you're taking the spleen out, you know, honestly, the easiest way is if you have, do any of you guys have vessel sealing devices at your clinic? If you're going to be doing splenectomies, it is so worth it to just buy one, and you can use it for other things. You can do your space with it. You know, it's very versatile, and there are a lot of options nowadays that are available. But if you have that, you just go right across the hilus. You know, it's easy as shit, and they have all these little vessels there. It takes about 35 seconds to do that. Now, you can also, if you don't have that, you can individually ligate them, and you know, it takes a lot of time, you know, to do that if you're going up by the hilus. So that's probably the most efficient, well, not the most efficient way, but that's like the most hemostatic way to do it. I would tell you that if it's bleeding, what is better if you don't have ligature and stuff like that is to just clamp the vessels first, get the spleen out to stop the bleeding, and then start ligating things. That way you don't have to panic and worry about, you got the bleeding stopped at least. There is a technique that I think some people talk about where you it's like a 3 ligation technique, and so if you look at it, that's a way to efficiently take a spleen out without spending a long time ligating all of this shit up here. And basically what you do is you take it down, if you look here, you can see the branching. There's kind of 3 major branches that come up here. So you can ligate right here, and that'll take down this whole section here. So 1 there, and then you can ligate the second one right here, and that'll take down all this there. You don't have to worry about the short gastrics. That's an old thing that we used to worry about, but there's such a good collateral supply to the stomach that you're not going to cause any issues with that. So you can do that pretty easily. So 1 right here, 1 right here, and then that's the 3rd one right there, and that's where all that short gastric plexus is. And that way you've done 3 ligations, you get it off, and you're fine. Now, I will tell you that looks really easy on an image like this from a textbook, and we all know that nothing looks like it looks in a textbook when you get in there. Sometimes these splenic masses have lots of adhesions and momentum around it. There's also, like, a lot of dogs create weird blood supply and angiogenesis to it. So ligate what you need to ligate. I guess my point being is stay as close to the spleen as possible. And that way you don't have to worry about any other things. Some people will, before they do all this, they'll just ligate the splenic artery and vein, the big one, prior to doing that. And that's fine too, but if you're up here, you don't really need to, because these are all smaller than that and you're ligating it. So those are the kind of the easy ways to do a splenectomy. And I think the next slide is on the vessel ligation. So yeah, this is the individual ligation up here that, and the 3-point one I talked about. And then the next slide I think talks about the ligature. If you're using this, remember that it's 7 millimeters is kind of your max that you can safely ligate with a ligature. There are some other ones like the harmonic scalpel to be careful of. I think it's about 5 millimeters for those. But a ligature and most vessel sealing devices nowadays can safely ligate 7 millimeters, which This will be bigger than 7 millimeters in many large breed dogs, but you're not ligating down, you're not cutting down there. All of these vessels almost certainly are going to be less than 7 millimeters. Every once in a while you get a big one there, just ligate it, you know. And the other important thing to know when you're doing the vessel sealing device, which I'm guilty of too, and some people are, is some people just like to double burn it. That's actually, you have to be careful with that because the manufacturer's going to say, show if you double burn on the same singe line, it actually weakens your seal. So if you do double burn, which you don't have to, you want to do a 50% overlap on your previous sear to do that. But if you're going to be doing splenectomy, I promise you it is worth it to get a ligature and a vessel sealing device to do it.
Now, if I know that the vessel is going to exceed this limitation, but I really want to use the ligature, then I'll ligature everything else but that. So I'll go down the spleen, ligature all that, just like Pac-Man, just chomp, 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 and then I have the main vessels, and then I ligate them with suture.
Do you have a preference on ligature size, like whether it's like just the little small ones? Or
I mean, you could use either one. I like the spleen gun, man, because that thing just fucking takes
fast.
everything
It's
down.
everything.
Yeah,
Yeah,
you just take like 6 vessels at a time. I think it's called the Atlas.
Yeah.
And that one, I mean, the jaw tip is like that. But the precise sometimes is really good too. The hand pieces, if you're going to reuse them, there are some studies that show, because they're one-time use, right? But we don't use them one time. It's not practical. They're too expensive. But I think it's 10 uses. Sean, is that what it is? 10 uses, I think, before you should change it?
Yeah, I mean, I don't know the number, but I feel like that's what happens.
Yeah.
Because by the 11th time, it's melted. You can't use it.
And what I do is I tally the handle piece
We
with a
do too,
Sharpie.
at our
And once it gets to, after you use it, make sure you tally it. And then at 10, just throw it away. You'll pay for it off by the number of ones you're doing, but that's the thing with that. There they are.
So just a picture of all the different options that we're talking about here. Yeah, and I don't know how many folks here have like an LDS stapler in their practice. Yeah, and how many people have like hemoclips? Or where is it? Yeah. Oh, here we go. Hemoclips. How many folks have? Yeah. So a couple. Yeah. So these are not bad alternatives. They're a bit faster than suturing. They're not as fast as ligature, but they are options for you.
So, I mean, part of surgical, when you're doing this, you're doing surgical oncology, right? So it's good to think like a surgical oncologist when you're in there. And what you want to do is after you're done taking the mass out is kind of, ideally you'd want to biopsy any like draining organ. The liver drains a lot of stuff in the abdomen. So I typically biopsy the liver when I ever do a splenectomy. I just quickly take a little guillotine biopsy of it, unless there's an obvious lesion, and then I'll biopsy it. Now I say that, but there was a study that came out in 2014 that showed that a normal looking liver in a dog with a splenic hemangiosarcoma is very low yield to biopsy it because it didn't have really any cancer in those samples. Now if you looked at like the darker colored lesions, actively bleeding lesions, and multiple nodules, those are more likely to be metastatic disease. So if you're seeing these like pigmented, black, dark red things on the liver and on the body wall and the omentum, that probably is going to be metastatic disease. But sometimes just like liver lesions, like Shadi said earlier, can look very similar to any other things, just regenerative process. And also be careful sometimes in the omentum because sometimes it is diffuse metastasis. Sometimes it's just baby spleens that have like impregnated there over time. So, yeah.
Yeah, and then it also protects you legally, medically, right? Biopsy the liver, even though it looks completely normal, it helps confirm that at least the sample you took was normal, right? If it comes back as splenic hemangiosarcoma, you didn't biopsy the liver, and now the oncologist is asking, well, how the liver looked? Did you biopsy it? You know, it protects you legally to sample the liver as well, even if it looks normal. And then I want to bring up the question of concurrent elective procedures. Let's say you're doing a splenectomy on a splenic mass, and it just so happens to have like bladder stones. Do you remove the urinary bladder stones at the same time as the emergency splenectomy? If it's a large breed, deep-chested dog, has not been pexied in the past, do you pexy it at the same time that it's got a hemoabdomen while you're in there, right? And the question is, I don't know, it depends. When you talk to the clients and they say, hey, by the way, doc, while you're there, can you remove that mammary growth that he's had for like 3 years? And you're thinking like, really? He might die in 3 months of hemangiosarcoma. But, you know, so the conversation is this. Sure, we can. but I have the ability to abort those missions should the patient not be able to handle the anesthesia and surgery. And it gives you the option to opt out. If you're just not feeling comfortable, you're seeing the occasional VPC, the PCV is going up and down, and you still have to remove bladder stones, and that's going to add another 20, 30 minutes to your surgery, maybe longer, depending on your skill set, you can say, I'm not doing it. The dog's life is more important. We can always do a bladder surgery later, if ever, depending on what the diagnosis of the spleen is, right? The conversation with the owner should be as frank as that. We can do it. This is what the additional cost is going to be, but also I have the ability to kibosh that if I want. Yes, question?
One time in my career, I had a post-op Hemoabdomen splenectomy develop a GDV like 3 weeks later. And one of my surgeons was like, I've had that once also happen in my career. And for that, like, I typically don't PEC see them unless I feel like it's really worthwhile and they're doing well and they're fairly young. Is that something that you guys, do you recommend if the patient is stable or no?
The question is, do you recommend a prophylactic gastropexy in the dog with the appropriate signalment that are risk for GDV, knowing that there is some risk of GDV later on post-splenectomy?
Yeah, so I think it's a great question. It's a really, really good question, and I think that there's two big studies that came out a long time ago that evaluated the risk of GDV following splenectomy, and they sit on both sides of the argument. One said there's no risk, and the other one said there is a risk and a link to it. So what do you do, right? I'll tell you my approach and what I do. If it's a shepherd, if it's a deep-chested dog, if it's a Dane, I'm 100% PEC-ing that dog. I mean, if it's dying, you got to make a judgment call. But I think that you are setting yourself up for a risk of them going GD later. Now, you could always say, if they're not doing well, let's get through this. If it's benign, we'll come back and PEC your dog later. But I do think it is a possibility. And I've seen dogs bloat in recovery, and that sucks. Now, I'll tell you a couple things. Like, if it's like a breed that's not going to be at risk, I don't think it's a problem. Like, it's a pit bull, probably not going to be a problem. It's a little chihuahua, you don't need to PEC that dog. I'll tell you a couple scenarios. Like, splenic torsion, definitely a risk factor for GDV. So you need to PEC those dogs for sure. And giant masses. One, they're more likely to be benign. Two, I think that just creates so much space in there, and I would veer on the side of PEC that patient too. So I typically do. It's a pretty quick thing you can do to just get it done. And in my last lecture, I also talked, because there's there's some newer studies showing that you don't really even need to cut the stomach to do a PEC. So like when we're doing I do most of my laparoscopically, and you don't have to, there's studies now that show that if you just suture the stomach to the body wall, it'll PEC itself. Now, if I'm in a situation with a really critical dog that is hemoabdomen and it's an at-risk breed, I'm going to just quickly suture the stomach to the body wall. I'm not going to suture it, or I'll staple it. At least you've done something really quick. And there's stapled gastropexy studies too. So I'm on the camp of, if they're an at-risk breed, if it's a situation where I think they might bloat, I'm going to PEC them, or if it's splenic torsion or a huge mass, I PEC them. If not, I don't. That's my
yes. Same thought here. It's coming out again to client communication. If it's that risk patient, then I want to do it. But if the patient is dying, I'm going to abort, and then we can do it later. And it is also in all of our experiences. It's rare that this happens. Even though it's unfortunate when it does happen, statistically speaking, it doesn't seem to be that. At least in our own experiences with it.
And I would say also, like Shadi said, the client communication is important, because I cannot tell you the number of times pre-op when I have that conversation. Like, you need to talk to the owner before you do it, because they always think you're trying to sell them something, and how much is a gastropexy, and I'm like, man, I don't want to do this, I don't have to, but it's for your own good. But they will always ask you how much it costs, and there is a stigma out there with certain breeders that pexies cause problems. It's all bullshit. But talk to the client, make sure they have approval to do it before you do it. And then, like everything, post-op monitoring, like surgery doesn't end when you close the belly. You gotta monitor these guys really, really carefully. You should be keeping an eye on their blood pressure. EKG, I will tell you, I don't personally put every splenectomy on a post-op EKG. The criticalist I work with highly disagrees with me, but I didn't have a lot of issues with that. Now, if they're having a lot of arrhythmias intra-op and they're doing stuff, I will. Well, you know, I don't think it's wrong not to. It's definitely not wrong to do it. But if like it's a stable spleen that had no arrhythmias, I don't know if they're having arrhythmias post-operatively, but on my physical exams I haven't heard any, and I haven't had any like issues with that. So, but it's I would tell you, like, liability-wise, it's definitely not wrong to do that just to be safe. I guess my question is, if they're having DPCs, what are you going to do? Really, nothing, right? But if they convert, then you have a problem. So that's up to you guys. It's not wrong to do it. PCV, you should be monitoring that. You could consider coagulation support, you know, if you want to give them, if it's a really oozy belly, if they are kind of thrombocytopenic going in. I don't usually give platelet transfusions, but I will stick them on aminopropylic acid. Or, you know, sometimes these dogs, they've lost so much blood, they've lost all their coagulation factors too. So sometimes they need plasma, or, you know, if you don't have whole blood, or, you know, you don't get that much coagulation stuff in whole blood anyway. So like a packed red cell transfusion plus plasma is not wrong sometimes, and sometimes is needed. And then just monitor. Some of these dogs, they're gonna crap out on you, no matter what amazing job you did in monitoring. And who knows, is it DIC, is it SIRS, is it thromboembolism? I actually think thromboembolism is like very much underdiagnosed in veterinary medicine, and I anticoagulate all of my spleens post-operatively. That's a me thing, I'm not telling you to do that, but I'm trying to work on a prospective study now comparing prognosis, because I hate the ones that do great and they come in and a week later drop dead. And I think it's a clot, or they had an arrhythmia that we didn't know about. I don't know the answer to that one, but I send all my spleens home on Plavix. And there is a study that showed they're hypercoagulable for 2 weeks following splenectomy, but there's no general consensus to do that yet. But I do, if you're worried about, like, they're kind of acting like clotty, like, you know, they're maybe having some respiratory, I don't think it's wrong to start them on an anticoagulant. That's just me.
And then in terms of frequency for these things, for blood pressure, I'd say continuous is ideal. Otherwise, maybe every 6 hours, it's good to check it. Obviously, that's assuming that each blood pressure measurement is normal. If it's not normal, you're going to try and correct that and recheck. ECG, same thing, either a continuous ECG or spot check it every 6 hours with more frequency if you're seeing abnormalities or if you're treating abnormalities. PCV total solids, I'd say probably, depending on how concerned you are from surgery, either like literally intra-op, you're checking it, or right after surgery or within the hour after surgery is done. But at minimum, I'm going to check it probably 4 to 6 hours post-op is my first one. Don't check these things like every 2 hours. You know, maybe after the first overnight post-operatively, maybe once or twice a day, depending on the clinical signs. Obviously, if the pet is showing signs of anemia, then you've got to assess blood pressure, heart, and then PCV. But those are kind of rough estimates, I'd say, for frequency. I don't know if you do something different, or is
no, I'm the same way. I mean, I think that I kind of do it as needed, depending. If they're not super anemic, I'll kind of just take it easy and not maybe like twice a day or once a day. I agree. Yeah, I mean, so like, and make sure you post-op pain control these guys. You're doing a big incision, you're taking spleen out, you know, and again, other things can be uncomfortable. So, you know, I think a pure opioid is pretty kind of needed for these guys, like fentanyl or intermittent opioid administration like methadone or hydro. I really don't think TORB is appropriate for these guys post-op, and people do it, and it makes me sad. Even buprenorphine, and the other reason I don't like that is if you start developing a problem post-op, like, you can't reverse that. So I stick to the pure Muse, and then I add, you know, if I need more, I'll do like lidocaine or ketamine, and, you know, I think it just helps them. NSAIDs, I use them in, you know, there's no reason not to use them in a splenectomy, you know, so that's a fine thing to use, you know, and that's probably the most effective pain thing we have in dogs, you know, like I don't use them for GI surgery, but I use them for like other stuff like this. And then, I mean, local analgesia also really important. I think NoC does a great product, and there's a lot of studies out now showing extra-label use in soft tissues and no increased risk of infections, and comparable. As even one study just came out showing no difference in pain control in dogs who underwent amputation when they had a single dose of Nocita in the femoral and sciatic nerve versus an epidural. So it's a very effective product that works. You know, if you don't have it, just use a line block of Pivocaine. Crystalloids, blood products, you know, antifibrinolytics if you need it. Again, we talked about kind of coagulation factor support if you need it. Anticoagulants, I went on my rant about that. And antibiotics, right? Like, they don't need them. I mean, you know, there's no need to send a dog home with antibiotics prophylactically for a routine splenectomy. Now, if you have some contamination or something or terrible skin, then yeah, but just perioperative is really all you need. And how do they do, right? Well, we know that the prognosis for splenic hemangiosarcoma, well, this is just a general perioperative study that looked at general hemoperitoneume of many different causes that came out in 2013. And it showed that if you look at it, 84% of dogs survive. So a pretty good amount of them will do fine, regardless of what the etiology is. But there were some things that were associated with death, respiratory disease, because that probably was going to be PTE or ARDS a lot of the times, if they need a massive transfusion, and tachycardia. Interestingly, the presence of splenic disease was positively associated with survival and discharge. So just a general study that looked at like factors, they do pretty well,
And if I know we're nearing the end of our time, if folks want to take a picture of these next couple of slides, it just helps you with prognostic indications as well as tell pet owners if they're trying to decide, do I do this or do I euthanize, what do I do? There are certainly some predictive factors for, these are predictive factors for whether or not you're dealing with a cancer of the spleen, just to be specific here on this slide.
And then, unfortunately, despite all this advances we've had, the prognosis for splenic hemangiosarcoma is pretty still shit. It's like 6 months with chemo and surgery. Sometimes you can get up to 9 months. Very rarely you'll have that outlier that I question maybe a wrong biopsy. So it's still good to educate you. This is a nice study that just came out in 2023 out of Brazil, and you can see the numbers really haven't changed that much. It did this one looked at clinical staging, using like if they had metastasis and stuff like that, which did have an effect on the prognosis. If you look at stage 3, dramatically less survival than if it was stage 1, localized to just a spleen. So important things there. And I guess in lines with this, I would tell you that don't be afraid to get a second opinion on the histopathology. Sometimes if you're like, that spleen looked terrible and it came back as benign, get a second look. And if they still come as benign, I sometimes, if I just had a clinical worry about it, I have them come back in like 3 months and do an ultrasound, just to make sure.
And then another slide for your own information. This is kind of a general synopsis of the literature with regards to survival times. If folks want to take a picture of that, you're welcome to. But this is specifically for hemangiosarcoma of different stages. And then other prognostic factors, again, to help you with your client communication. Feel free to take a picture of the slide and just more information to try and talk to the clients. So all this stuff is related to splenic cancer specifically. Yeah, and any questions? This is Justin's contact information here. Please take a picture or follow him. And then this is my contact information here as well for folks who want to follow. And yeah, any questions you guys have, we're happy to answer. Yes?
If you are worried, like I had one recently where there were a lot of adhesions and the pancreas was really like pissing on the spleen, so we just had to break things down. If you were to use those pancreatic vessels, are you just worried about like decreased blood flow, or is there a chance of necrosis?
So the question is, if you have to manipulate the spleen because it's basically adhered manipulate the pancreas because it's adhered to the spleen, how worried do you have to be about injuring that pancreatic blood supply? What's the concern there?
It's a worry. I don't think you're gonna. We were very lucky as veterinary, professions that we have dogs that have such good collateral blood supply to a lot of things. So I don't think you're gonna kill the animal doing that. But I do think there's a risk for pancreatitis, maybe a little bit of pancreatic necrosis. But they can tolerate that. It just might be a rocky recovery. I would try to do your best to preserve it and move it away. And if you see that clearly it looks like it's changed, you can do a partial pancreatectomy at that time. And I would tell you that sometimes, especially in splenic torsion, everything is wrapped up in it in the pancreas. You gotta be real careful. That's the one thing you gotta try to get the pancreas away from it and just stay as high to the spleen as possible. But it's a tricky one. I would just prep that owner that there's a lot of adhesions and it could be. I would just keep an eye on that dog post-operatively a little bit. The adhesions also is another thing that you don't take them too lightly, like ligate them, because sometimes they have pretty big vessels in there that will be a source for a post-op bleed that wasn't your doing, but sometimes they deserve to be ligated.
If you don't have those sterile Q-tips, that's really good for teasing away delicate tissue. It's slow, but it'll help more so than using that rough gauze pad or your fingers. So
do you think cautery is too aggressive, or because you said use the little Q-tips?
Yeah. So the question is, do you think cautery is too extensive, too aggressive? No, I think it's fine depending on what you're trying to achieve, what you need to do. Yeah, I don't think there's any big
Yeah.
detriment there.
Just be delicate with it, you know, you like, and yeah, there's other issues, but like if you're kind of like, you can be very fine with cautery.
We're using a combination of these things. You know, we're going from digital manipulation to the Q-tips to ligature to cautery. Like we're just constantly back and forth, back and forth. You know, we have probably like an internal residence retracting everything, so we have the perfect, you know, so we can just sort of go back and forth with trying to manipulate this to get the job done. Any other questions? Thanks, folks. Enjoy the rest of the conference.